Good evening. My name is Meet, one of the FNP student. I have Mr. Dylan here for my neurological assessment uh, video. Uh, I wash my hand, arrange my all instrument for the procedure for the assessment. I'm gonna ask Dylan for his consent to getting this video. Is okay if I take this video assessment for my professor to grade me?
Yes.
Thank you. So for neurologic examination, we always check about patients, the way they walked in from the starting. We start observing how the patient is walking, behaving, and all stuff. But for this examination, we'll start with the memory. We'll ask the patient about the recent memory and the remote memory, asking a patient, what did you have for your breakfast?
Breakfast, I had a biscuit.
And you know how was the weather today, this morning?
It was sunny.
Great. And for remote memory, normally there are many different things people ask, but I will ask, do you remember what happened? When was the World Trade Center attack happen?
That was September 11th,
September 11th. Do you know what the year was that?
2001.
Okay, so that is a pretty good memory to remember. Now we move on to our second thing is reasoning examination, which for that I'm going to give a scenario to Dylan and let's see what his reason is about. So Dylan, if you're going for an evening walk and you found a letter on your walk on the way to walk and it says its address and stamp, what would you do?
I would put it in the post box.
Okay, so normal person will do put in the post box. If somebody who is not with their mind, they probably either throw it back or even they tear up. But making reason for doing the right thing, it's that's a correct thing. Now we move on to our cranial nerves. We total we have 12 cranial nerves. We'll check one by one cranial nerves, but I would like to tell all the cranial nerves at the beginning. Cranial nerve 1 is optic. Cranial nerve 1 is olfactory. Cranial nerve 2 is optic. Cranial nerve 3 is oculomotor. Cranial nerve 4 is trochlear. Cranial nerve 5 is trigeminal. Cranial nerve 6 is abduction. Cranial nerve 7 is facial. Cranial nerve 8 is acoustic or the acoustic for the ear. Cranial nerve 9 is glossopharyngeal. Cranial nerve 10 is vagus. Cranial nerve 11 is accessory, and cranial nerve 12 is hypoglossal. So now we'll start with the first examination of cranial nerve. Is asking patient to first to can you breathe for one nostril and other one, so that shows that patient nostril is clear and patient able to breathe. Can you close your eyes? I'm going to give you something to smell, let me know what is it. Okay,
Okay.
can you smell what is that?
Coffee.
Correct. So cranial 1 is intact. Now we'll move on to our cranial 2, which is optic nerve. For that we do a couple of tests to make sure the cranial 2 is intact. The first one is I'll ask the using the Snellen chart to see if the patient can able to read that with the 6 feet distance. So do you want to move your chair a little bit backward? That's glad. And can you able to read the lowest line or whichever line you can able to read from here? Wait, can you close your one eye, please? Yeah.
LTFPH.
Perfect. And what about the next eye?
LTFPH.
Okay, can you do with the both eye open?
LTFPH.
Okay, so patient was able to read LTHPH was 20/20 vision, which is optic nerve 2 is intact. Now I'm going to check the patient peripheral vision by asking patient to tell me when he can see my two fingers or my hands move coming towards his peripheral vision. Tell me when you can see.
No.
Okay.
No.
Okay, so that shows the patient peripheral vision is more intact. Now we'll move on to we can do even the check the patient pupillary reaction with the pen light, but I would do the ophthalmoscopic examination for the patient, fundoscopic examination for that. All right. So for doing the fundoscopy examination, I would like to see the patient eye, and I'll look at patient ray reflex first, and then I'll look at patient optic nerve disc, and is there any vessels, is there any kind of abnormalities going on or not. For that, I'll look at for patient right eye to my right eye. First, I'll go at the side, look at the patient red reflex, which I can see. Now I'm using the safety measure by using my 3 finger in the front. I can see the red eye. Okay, I can see the optic nerve. I can see the vessels. Optic disc is sharp, and cup to disc ratio is 1 to 3. There is no abnormality. I can see nerve, and there is no woolen cotton inside. Patient optic nerve looks good. So right eye examination, we use the right eye to right eye. I'm gonna go to the left eye. By same thing, we follow from the side. Make sure that I can see the red reflex, and I use my left eye to left eye, and I can see that. Come towards me, perfect. And I can see the optic disc, optic nerve, and the disc to cup ratio is 1 to 3. The vessels are looking good. There is no abnormality at this point. So we did the eye examination by using the ophthalmoscope, and the patient optic nerve 2 is intact. And now we move on to our optic nerve 3, which is oculomotor, by asking patient to look by, we can use it even the light thing, because it's oculomotor nerve 3 does help with the pupil construction reaction, by asking patient to look at my nose. Good. Yes, patient's pupils are reacting both side equally, and now I'll ask the patient to look upward, and patient able to look upward. His oculomotor nerve 3 is intact. I'm going to check here now cranial nerve 4 and 6 the same time, and then we'll check all 3, 4 and 6 together. So cranial nerve 4 is trochlear, which is, we'll ask the patient to look at downward and inward. Can you look at downward, and can you look at inward? Okay, and now I'm going to ask the patient to look at my pen, so, and tell me. Good. I don't see any kind of nystagmus. Do you have a double vision while you're looking at that? No double vision. Patient was able to look at that, and both eye turned to the side of the nose, and the patient does not have any kind of nystagmus or any cross eye at this point. We look at the cranial nerve 5, which is trigeminal, which helps for the mastication, and to check for that cranial nerve, I'll ask the patient to bite it. Perfect. And bite it. Perfect. Can you open your mouth? Good. Patient was able to open the mouth with my hand resistant. And while checking the cranial nerve 5, I'll ask the patient to close the eyes so we can check the sensory function of the nerve. Can you close your eyes and tell me where I'm touching, okay? Or what kind of touch you feel? You can tell me.
Forehead.
And what kind of touch was that?
Soft.
Soft. Okay.
Soft.
What side was that?
On my right side.
Right side. Okay. And what side was that?
On my left side.
Left side. And how was the touch?
Soft.
What side was touch?
That's on my left side.
Okay. And was it sharp or soft?
Sharp.
Sharp. Good. So that was the cranial nerve 5 that we just checked, trigeminal nerve, and the patient was able to identify the dullness and sharpness. Now we'll move on to our cranial nerve 6, which is abduction, and that also we check the patient eye movement from, can you look at away? Okay, good. And can you able to look at downward? Perfect. And outward. Perfect. Patient was, and now I'll check all the 3 cranial nerves together. It's oculomotor 3, trochlear 4, and abduction 6, by using the pen, by making imaginary edge, by asking patient to follow just by the eyes, not with your head.
Okay.
Good. Patient was able to follow the edge direction without any nystagmus or the abnormal movement of the eye, and patient did not have any kind of blurry or double vision. So we completed 3, 4, and 6 and 5. Now we move on to our cranial nerve 7, which is the facial nerve. For that, I'll ask the patient, can you to check the cranial nerve 7, which is the facial nerve. I'll ask patient to can you lift your forehead. Perfect. Patient was able to do that without any difficulty. Can you smile? Can you frown your face? Can you pop your cheek? Perfect. So patient was able to do it without any kind of problem. So cranial nerve 7 is intact. Now we'll look at the we'll check our cranial nerve 8, which is acoustic vestibulocochlear nerve. That's the for ear. For that we can do 3 different tests. The first is a whisper test, second is a Weber test, and Rene test. So first whisper test, I'm gonna stand behind the patient and ask the patient to able to recognize my word what I just asked him.
Apple.
Good. Another one.
Banana.
Banana. So acoustic vestibulocochlear nerve 8 is intact. By patient was able to easily able to hear my voice saying the apple and banana. Now I'm gonna check. I'm gonna use my tuning fork to check the patient's Weber test while asking patient whether he can hear on the both ear or one ear. Can you hear both side or one side?
Both sides.
Okay. Patient was able to hear on the both side. Now I'll move on to do the Rene test. So I'm going to use my tuning fork and use it on patient the my mastoid bone behind the ear, and ask the patient when they stop hearing, and then I can able to put it in the front ear and ask them whether they can still hear. Tell me when you stop hearing.
Stop.
Can you still hear?
Yes.
Perfect. And I'm gonna do in the another ear also. Tell me when you stop hearing.
Stopped.
Can you still hear?
Yes.
Perfect. So Rene test, and it's normal too. Patient was able to hear after taking out from the mastoid bone from the back of the ear. So the air conduction is greater than the bone conduction. Now we'll move on to our cranial nerve 9 and 10, which is a glossopharyngeal and vagus nerve. For that, I'm going to ask the patient to check that cranial nerve. I'll ask the patient, can you able to swallow? Can you swallow? Good. Patient was able to swallow, and I'm gonna check the patient cranial 9 and 10 by using aka spoon for the tongue depression to asking the patient to say ah to check the patient uvula whether it's in the midline or which side is going. Can you open your mouth? Can you say ah? Hold on, let me get my pen so I can see you. Okay, one more time. Okay, patient was able to say ah, and uvula is the midline position and moving upward when the patient is saying ah. So can you know 9 and 10 is intact, and I can to check that we can do the gag reflex, but patient is able to talk to me clearly and able to say, so patient had a good gag reflex. Now we move on to our cranial nerve 11, which is accessory nerve. For that I will ask the patient, go to patient behind and ask the patient to slap the shoulder to see. The patient able to do that. Can you able to move your neck side to side? Perfect. Can you look at on that side? Side. Okay, now I'm going to ask the patient to look with the same. Can you look at? Perfect. How about now? Okay, yeah. With the resistance also, patient was able to look at pretty good. So cranial nerve 11 is intact. Now we'll move on to our cranial nerve 12, which is also connected with the 9, 10 and 12 normally together. So for to check the 12 nerve, I'll ask the patient to, can you stick out your tongue? Perfect. The patient was able to stick out the tongue, and I'm going to ask the patient, can you push with your tongue? Okay, how about here? Perfect. And for cranial nerve 5, that one more thing I forgot to ask the patient to, can you able to move your jaw side to side? Perfect. Patient was able to do that too. So that also another way we can check the cranial nerve 5, trigeminal nerve is intact. So we completed our 12 cranial nerves. Now we move on to our another further examination in the neuro is the cerebellum by checking the patient gait, which I already knew when patient walked in, but we'll ask the patient to do it again. Can you able to, you can walk from here to there.
Okay.
Can you able to walk straight? Perfect. Patient able to walk without any problem. I'm gonna move my camera a little bit lower so you can see. Can you do the tramped walking? That's it. Tramped walking. Patient able to do that. Okay, now I'll ask the patient to walk on your heel. Can you walk on your heel? Walk more so we can see in the video. Yeah, patient able to walk on the heel. Perfect. Now can you walk on your toes? Yeah, can you walk? Perfect. Patient was able to walk after 12 hours shift. So we check the patient gait by making him to walk, and again we check the patient tandem walk, which is walking 1 foot on top of the in front of the other feet without any imbalance, and patient did walk on the heel and the toe. Now we'll check the patient rumbar test, and then we'll do the pronotal drip test. So can you stand up?
Yes.
And stand to your front. So yeah, you can show me your hand this way. Yeah, come here. Okay, so patient, close your eyes, and let's see patient how long patient can hold. Normally 20 seconds is the time where patient able to hold it pretty good. So here without any problem patient able to do it now. So the rumbar test is normal. We're gonna do the pronatal drip things. So when I do that, let's see what he does. So when I push it hand down, it came back directly to the normal position where he was standing it, where the eyes was closed. So that is normal. There is no problem with the cerebellum. So if the patient would not able to do that, the patient would have some kind of lesion or any kind of problem going on with the cerebellum, which is the balance. So once we're done with that, I'm gonna check the patient rapid alternate movement of by asking patient to do 2 different tests. We can do either the hand flapping thing, or we can do ask the patient to follow nose to finger, and we can do nose to finger first. So can you put your finger on your nose, and you can look at me, and can you touch my finger? Can you touch your nose? Can you touch my finger? Can you touch your nose? Can you touch my finger? Perfect. Patient was able to do it without any problem. If patient would have any kind of neurological problem, patient will not able to get exactly target to finger to nose. We can ask the patient to, I'm gonna put my camera. Can you do this? Show your hand, planter, and put on your leg, and do it faster how much you can. Yes, patient is able to do that. That's very normal. If the patient will not able to do that, has a coordination issue, then there is a much more examination needed to clarify what's going on. So we complete. So then one more other thing is connected with this is we'll ask the patient about the following instruction. Can you able to stand up, please? And just stand there. Can you bend your knee? Perfect. Patient was able to follow the instruction. Have a seat. And no problem with that. So patient was able to follow. Now we'll move on to our next examination, which is sensory. So for that I will use my, okay, so for that we'll ask, normally any sensory exam we'll make sure the patient eyes are closed while we do the test. So first we'll do the joint sensation. I'm not gonna tell. I'm gonna tell him to close eyes. Can you close your eyes and put your leg together? And I'm gonna use a little bit sharper thing so he can feel with this uniform thing. Okay, so tell me which side of the joint I'm touching it. Okay, and we are doing the joint sensation examination.
Left side of left knee.
Okay, can you point out with your finger where I'm touching it?
Right here.
Perfect. And perfect. So patient was able to identify easily, direct without any kind of trouble with that sensation. Now I'm going to use the 2 point sensation. I'll ask the patient to close the eye, and I'm going to ask first. I'll start with the 1, and then I'll start with the 2 sensation, so to see where patient is able to identify is it a 1 or 2. So I have my pencil, and I have to check my 2 things here. Okay, so can you close your eyes and tell me if it's a one prick or you feeling 2 prick? Okay.
Okay. 1. 1. 1. 2. 2.
All right, so patient was easily identify sensation 1 or 2. We can do on the feet now by, so I'm going to put this camera here so you can see. Can you close your eyes?
Yes.
Okay, tell me if it's 1 or 2.
2.
Perfect.
1.
1 or 2. Do it again. 1 or 2.
2.
Okay, one more time.
1.
Perfect. So patient was able to identify in some areas. Sometimes when you use 2 point for sensation, some of the areas are like, especially on the hand, sometimes if you put 2 together, patient will able to say 1 because it is a very short area. But if you use in a wider angle, patient able to tell is it a 2 prick, even though you pushing at the same time. So now we move on to our asking. Can you close your eye?
Yes.
Okay, I'm gonna check for patient stereognosis by asking patient to close his eyes and identify what I'm putting in his hand. Can you in the front? Can you close and see what's that?
A spoon.
A spoon. Patient was able to identify spoon. And now we're gonna do the graphiothesia, which is asking patient to close his eyes, and I'm going to draw something in his hand and he can able to identify or not. We'll see.
3.
Number 3, that was correct. So if patient has any kind of cerebral or any kind of neurological problem, they will not able to identify object or the word that we written. So stereognosis is for the object. We can give any kind of object. It could be key, pen, or spoon. And graphiothesis is like you write any kind of alphabet or the numbers, and patient able to identify that. So now we'll move on to our next examination. Is okay. So now for sensation, I will use a tuning fork too, because that's for sensation. Can you close your eyes? Can you able to feel the vibration?
Yes.
Perfect. Can you feel the vibration?
Yes.
Perfect. So patient was able to feel the vibration, that sensation for sensation test, and patient was able to follow all the instruction as I told you, so there is no problem in the sensation too. Now we'll move on to our motor function, which is we'll check. Oh, so sensation, there is one more thing left that we'll check patient sensation by asking patient upper and the lower extremity, which is sensation for superficial tactile sensation and superficial pen sensation. So can you close your eyes and
Yes.
tell me which part of area I'm touching, which is soft or sharp? Let me know. Okay.
Okay. Right arm soft.
Perfect.
Left arm soft.
Okay.
Right arm sharp. Left arm sharp.
Okay, we're gonna lead your leg.
Right leg sharp. Right leg soft. Left leg soft.
Perfect. And last one.
Left leg sharp.
Perfect. So patient was able to identify the soft and painful sensation with all the extremity, upper and lower, without any problem. Now we'll move on to a motor examination, which is a upper extremity and lower extremity. We're going to check the patient shoulder, bicep and tricep. We'll check the patient strength, as well as we're going to check the patient finger strength and their comparison too. And we'll mark it as a grade. So let's check the patient strength for the hand. Can you move your hand? Can you do your hand this way? We're going to check the patient bicep and tricep strength. Can you push me? Oh, good. Can you push towards you? Oh, so his bicep and tricep has a pretty strong. He was pushing me back, and I'll ask the patient to push my hand away. Oh yeah, okay. And can you don't let me put it in? Oh wow. So the strength is equal on all the bicep, tricep, and shoulder, and the grade is 2 plus, and the patient was able to go against the gravity and with the gravity. And now we check the patient grip. Can you cruise? Wow, patient has a really strong grip. He can able to really grip my hand. Now as the patient, will check the patient finger. Can you don't make sure, can you able to make your finger this way, close it? Okay, patient able to do that. So I'm going to make sure, open your finger and don't let me close it. So I'm pushing the patient pinky with my pinky, so pretty strong. And I'm going to use my first finger with their first finger. Check that. Patient was good. Now I'm going to ask the patient to close it and try to not to make me open. Okay, pretty good. He has a resistance. Like sometimes we can do it, but it shows not too much resistance to open up. So that's that motor part is intact. Now we'll move on to the next one, but I still need to check the patient deltoid by asking patient to, can you push it? Good. Don't let me push it. Okay, put your hand up, please. Yeah. So deltoid muscles strength is 2 plus, and is strong. It was bilaterally strong. Yeah, and then we do the fist. Patient fist. We're gonna check the patient fist by, I'm trying to open. Make sure you don't let me open. No, that's pretty strong. So even the patient fist is stronger, and he was not able to, I could not able to open it. Now we'll move on to our lower extremity. Okay, so for lower extremity, I will ask my patient to get a little bit move backward. We're gonna use other thing. I need my stuff here. Okay, so for lower strength, we're gonna check patient hip, patient knee, patient ankle, and the feet. Fourth thing we're gonna check it, and we check the patient strength for that, and we're gonna check patient what is that muscles? Squat. So we're going to check the patient's strength with the quad muscles and the hamstring muscles and the patella in the front. So let's check the patient's strength by doing the while doing abduction and adduction by checking the patient's strength. So don't let me push in, okay? That's good. Can you push it in? Push it in. Good. So patient strength for checking the muscle strength is equal, and he was patient able to do abduction and induction of the quad muscles. And now we're going to check the patient strength for this the lower extremity. Can you able to up? That's a flexion. Back, perfect. And we do here also same thing, up, down. Okay. and we'll check the patient. Let me put this down so you can see. Strength. Can you able to, how we put it this one?
With the plastic thing underneath.
Tell me when you see her. You see that?
Yeah.
Can you move back a little bit? Okay. I think you should go a little bit more back. Perfect. Okay. So we did the squat muscles, and this is the hamstring muscles. We check that. So we check the strength by asking patient to push it away and push it in. So that's pretty strong. And we compare the grade is 2 plus, and it's a strong. Now we'll check the patient the hip. For that, how are we gonna do? Okay, you might have to lie down, right? Is it? We can do it here. Slide down on the bed. I'm going to check the patient's hip. Perfect. Now, so we'll ask the patient to lift his up. And other one. Okay, perfect. Now I'm going to, can you bend your thing? And I'm going to do the rotation, external rotation, and the same thing with the other leg. External rotation, internal rotation. And when patient is lying, we can tell them, can you bend your knee? Can you bend both? Okay. Ask the patient not to push me away from each other. That's pretty strong. Can you push it out? Pretty strong. So you can see the hip muscles are strong, and patient was able to do that. Now we'll move on to, okay, one more thing if it can do. You want to lie down on your tummy? And can you?
Like this?
Yeah. Can you able to move your feet up? One at a time. Lift up, completely up. Perfect. 1, and do the same thing again. 2. So patient was able to move. The hip is intact and it's strong, and without any difficulty, patient was able to move the hip. You can sit down, and we can do your deep tendon reflexes with my hammer. So for this one, I'm going to use my hammer. I'm going to check the patient bicep, tricep, and reflex on the popliteal reflex. And sorry, we can check the Achilles reflex, and then at the last we'll do the Babinski reflex. So for bicep, I'm going to use the patient arm, use my things, and I'm going to make sure the patient able to. So I'm going to hold the tendon here and then use my hammer. I can able to see the twitching, and even the twitch patient hand also, you can see that. Yep. And then for doing the tricep, I'll ask the patient to raise his hand on here, and I'm going to use this tendon. Sometimes we like to use our hands so patient don't get too much pain. I'm going to see the lateral movement of the tricep, and sometimes the hand also moves. Okay. And good. So you can see the movement. That's a tricep we check. Now we're gonna do the Achilles tendon reflex. By normally it's easy to do when the patient is either sitting. Go more back, and then we normally check on the patient here. What is the easiest way?
Just put it on the floor.
So this is the where we check the patient Achilles reflex by using my hand on the back tendon, and you can able to see the patient move. Yep. And one more time, we can able to see the patient legs will move. Good. So sometimes it's easier more when the patient lied on the back and putting the leg this way, so you can able to see the patient move backwards. So that's tendon reflex. So 2 plus is normal, and I felt all bicep, tricep, Achilles reflex in all of them when 2 plus. And sometimes we even check the patellar reflex by looking the patient, holding the patient leg this way and using the things, and we can see the movement of the leg. And you can see the jerking movement of the leg. Let me see. Put your leg over here. And yeah, so that is intact, which is 2 plus. Tendon reflex, it's normal. And we do the last one is a bobbin skin. We can use, and you can see the patient. So normally we go from up to inward to outward, and we can see what patient thinks that. Okay, let's take, that's fine, take it off. Much easier, so you can see the reflex. And it's moving, so that's perfect. So the patient moving inward ends up going fencing outward. So if patient would have fencing outward, means that he would have some kind of neurological problem, and we could not do the test today. Okay, and I want to make sure that we don't forget. So cover the cranial nerves and sensory, variable sense, everything we cover. Anything else? Let me put this up. Is it good?
Yeah.
Okay, I think the neurological examination is done. Most of the things we covered today for the examination. Thank you for Dylan.
Of course.
After 12 hours of shift, we'll be doing that. Thank you so much.